everybody. So welcome you all to this 9th session of the series. We're going to be focusing on the transferability of econ evals to your situation. So undoubtedly you will be looking at literature reports and trying to figure out, well, is this cost effective? And rather than just by saying, oh, this is done in Canada, so therefore it must be, it's much better to actually apply some methodological criteria to making that assessment. So thank you very much to Professor McCabe, who's going to be giving this talk on transferability, and the floor is yours. Thank you.
Thank you very much, Andy. Good to see everyone again. Introduction to transferability and generalizability. Wouldn't it be nice if somebody had already done the work for us? There's all of that published literature. Wouldn't it be nice if we could just take that and use it to inform our decisions? Sometimes we can, sometimes we can't. Often, actually, it's a judgment. But what's required of us as analysts is to be systematic and transparent about how we do that and to use the best methods available. So I'm going to talk a little bit about the problem. Now, there's two components here. I'm going to talk about how we do it, how we deal with economic evaluations that have been undertaken alongside a clinical trial. How do we think about generalizability and transferability when the evidence is part of the clinical trial study? And now I'm going to talk about what we do when actually evidence from a clinical trial has been synthesized with other evidence, local evidence quite often, to produce a model-based cost-effectiveness analysis. How do we deal with assessing whether we can use them to inform the decisions that we have to make here in Alberta or wherever else we're based? So, problem, how do we judge whether we can take the results of an economic evaluation undertaken in a different setting and use it to inform decisions about resource allocation in a different healthcare system, our healthcare system? That's our problem. So, economic evaluation alongside clinical trial, they will almost never provide all of the information you need to take into account to make a decision on the value of a technology here. We will almost always have to extrapolate beyond a trial, beyond the time period. What can we, how do we deal with that? Frequently, we'll find that people make an argument or an assumption of a constant relative effect. They say, well, look, it's pretty stable over the trial period. So can't we assume it's pretty stable subsequently? And the answer is, well, probably not. Because the factors that are driving that constant relative effect may actually vary such that it's no longer a defensible assumption. As we get older, we accumulate comorbidities. Comorbidities impact upon both our capacity to benefit from a health intervention and directly on that health intervention's effectiveness quite often. And so as we extrapolate further into the future, assuming that what we've seen in a clinical trial for costs and effects is really problematic. What we see as well as the extrapolation is the question about, well, this trial took place in 14 different countries, 14 different health systems. Can we use that to tell us what we'd expect to see here? And so we see statistical approaches, econometric approaches, where we receive analyses that are subgroups of the trial data for the health system of interest. And we see them in the most naive form, where they just pull out the data for the health system we're interested in, Canada, Alberta, whatever, the UK, and say, well, what does it look like here? And what we do, or what's being done there, is they're throwing away a huge amount of information. Because the data from the other health systems still gives us insight into the relationship between costs and effects. and the relationship between the baseline characteristics of the patients and their costs and effects. It's not perfect, but it's information that we should look to use. And so instead, we get more sophisticated approaches where we look to use tests of homogeneity, heterogeneity by health system. So we may look and see that the analysts fit fixed effects or random effect models in predicting the net benefit, or they may fit those regression models for the costs and a parallel regression model for the effects, looking for that clustering, the fixed and the random effects at the health system level. Problem is, trials aren't typically designed to power those tests. So it's very easy for a test to come out as no significant difference, but actually the sample size isn't actually sufficient for the test to be well powered. So we can get misleading results if we do that. Another way forward is multi-level modeling to produce health system specific estimates of effect and costs, which draws on that information about the correlation between effects and costs that's in the other health system setting. So it's a way of avoiding throwing away all of that information while still recognizing the differences between the health systems. But we're still in a slightly unsatisfactory place because we're having to assume that no confounding systematic differences exist between the health systems. And we're having to assume that the time horizon of the time horizon of which we have data in the trial is sufficient for us to build robust models extrapolating out into the future. So we're making quite heroic assumptions about what the data looks like for the time that we don't observe and for the characteristics of the health system that aren't observed in the trial. And so what often really happens is we synthesize the trial data with observational data that's health system specific. And another way of describing that is that we build a cost effectiveness model. And so this was something Mark Sculfer and I wrote with Carl and Mike quite a long time, 2006. This started as a rant at an ISPOR conference in Crystal City, just outside Washington, D.C., when Carl and I were getting very cross about ISPOR's guidelines for economic evaluation alongside clinical trials, because we're very strongly of the view that actually trials are just a way to get evidence, but actually to inform a decision maker, you have to build a model that addresses the decision they're interested in, and that trials are almost never about a decision. They're almost always about testing a hypothesis. So to go back to one of those early lectures I gave where I said, this is one of the big differences. Economic evaluations are undertaken to inform decisions. They're not undertaken to test hypotheses. And that means the design of a trial is ill-suited to the work of economic evaluation and cost-effectiveness analysis. So we wrote this in 2006, and I noted over the weekend that Mark reiterated this just last year with a repeat of the arguments in Value in Health. The fundamental issue is that trials are not designed to inform decisions, and certainly not decisions that have very long-term implications. So they're quite nice as vehicles to collect data, but actually not all data. Data on resource use, data on unit costs, data on clinical behavior, data on patient preferences, those are things that actually can be collected more appropriately in other forms. Another area of data that we really don't get in trials is about the case mix of our population. Our population is young for Canada. And that impacts upon the expected benefit of healthcare. And so that data we have to get for ourselves in our own health setting. We shouldn't be doing it or thinking we can use trials for it, because the truth is we can't. So, having basically arrived at a conclusion or an argument that I would say clinical trials and economic evaluations alongside clinical trials especially are not generalizable and are not transferable because they're not designed to address the needs of decision makers. I'm going to talk about, well, what if you've got a cost effectiveness model? How do you deal with transferability there? Thankfully, there's been a fair bit of work dating back over the last 10, 12 years on how you should do this. And the first really good paper was by Velt and colleagues out of the Netherlands. And they set up a really careful structure and process for evaluating the transferability of cost effectiveness analyses. And I just want to take you through that. There's been other papers done subsequently, but they've all built on it and essentially doing a very similar thing. So they start off saying there's 4 transferability factors. Groups them by methodological characteristics. So what's the perspective? Is it a societal? Is it a public exchequer? Is it a health system? Whose costs count? Because if it's just the health system's costs and you're interested in the societal costs, then that's a transferability problem. Talks about discounting. So how have we discounted? What's our attitude to time? Because that has huge implications for the weight that's given to costs and benefits in the future versus immediately. How have they approached costing? Have they used charges or fees? Have they used prices? Or actually, have they used the correct resource costs? What have they done? And is what they've done consistent with what is good practice in the health system that you're working for? And how have they dealt with productivity cost? Have they looked at it from a human capital approach or from a productivity friction cost approach? These are the methodological questions that you ask. And the question is, how have they done it? And is that how we do it here? Is that our best practice? And then there's health system characteristics. How like your health system is the health system this study was done in? Is clinical practice different? Are they a salaried system for doctors, or is it fee for service? We get very different patterns of treatment practice when we have salaries versus fee for services. What are the healthcare facilities like? Is this based in a tertiary hospital, in a high-tech health system, US, Texas, California, or is it based in a local district general hospital, as we'd say in the UK, or in a rural area? What's the availability of technology? Are the comparators that the doctors could choose the same as the ones we have here? Because what your choice set is determines what you use, and therefore determines the relative effectiveness of a new technology compared to what you use. You need to work through those. What sort of market have you got? Have you got a monopoly in the provision of services to the healthcare system, or is it a competitive market? These all affect the prices and the costs. You need to understand that if you are working in a different market environment, you're going to have different cost drivers, and therefore the transferability is a problem. And then there's prices, looking at the absolute differences between here and the healthcare system the study's from, and the relative differences. It might be all right if actually the relative cost of doctors and nurses is the same between here and there. But even if the absolute costs are different, but if both absolute and relative are different, then you can't use this study. You've got a real problem. So that's most importantly, I think, and one that in my experience is where borrowing a pre-done somewhere else study is a problem, is the population characteristics. The incidence and prevalence of the disease, the case mix of the people with the disease, their life expectancy, all of these vary from health system to health system. And that variation drives differences in the expected costs and effects, expected value of a new technology. And the only way you find out whether that difference is of a magnitude that matters is to actually do the analysis. You can't just assume that those things don't matter. We also have differences in preferences. You know, what we in Alberta want our health system to provide may be very different from what they want in Texas or what they want in the UK or in France. So how we value health can be very different. Behavioural factors, models, we often worry about, well, what's the compliance with this therapy? And what's the uptake of this therapy? Well, those are actually things that differ by the values of the population. I mean, in France, getting people to take tests is not a problem. Getting people not to take tests is a problem in France. In the UK, getting people to turn up to their doctor to take a test is a huge problem. You know, but if we took an analysis done in France to predict the expected cost effectiveness of something in the UK, it would be wrong because the behaviour of the patients would be very radically different in terms of uptake of the technology. And if you don't access the technology, it can't be effective. And so you don't get the benefit, even though the health system's paid for it to be made available. Okay? So it's working through in these systematic ways factors that can mean that the results from the published study isn't going to be reliably what you expect in the health system where you're trying to inform a decision. For certain diseases, especially viruses, infectious diseases, you also need to think about population density, immigration, emigration. So TB, in populations where you don't have much immigration, your modelling of the value of a technology for the prevention of TB is going to be very different from one where you've got lots of immigration. Dense populations, infection rates, transmission rates, going to be radically different from rural, more dispersed populations. You need to think these things through. So here we have just sort of an overview. You've got these transferability factors, and they can have both direct effects and indirect effects. And it's the combination of those direct and indirect effects that impact on the cost effectiveness. And so you need to think about not only, will this immediately change the effectiveness of this therapy directly, or is it a behavioural effect that will lead to changes in uptake or differences in uptake? So in everyone who takes it, it may be equally effective. But an indirect effect is people don't take it. And so the population effectiveness and the population cost effectiveness is different. So thinking whether you have worked through the direct effects and the indirect effects in arriving at the decision, can I use this study, is a part of the evaluation process. Velt and colleagues basically argued on the basis of a couple of case studies that what you see is effectiveness varies, utilization varies, returns to scale varies. So returns to scale, if you're doing something on a very large scale, because you've got a big population, your costs are going to be lower. If you transfer it to a smaller population, more dispersed population, your costs are going to be higher. So resource utilization, return to scale, and productivity loss. So the structure of the population in its economic activities actually impacts quite substantially on the value of a technology. You've got a young population that are all in employment, and you treat them and keep them in work. That's very valuable compared to a much older population who are mostly not working anymore, and actually you're keeping them in good health in their life at home, but it's not leading to increases or promoting gross domestic product growth. So those are their four big issues. So in structure, to make the decision, so I've told you all this information, talked about lots of reasons why they won't be transferable, but now I want to talk you through, well, how do you use this insight in a day-to-day way? How do you actually decide for a specific study whether it's transferable? And Velt and colleagues talk about knockout criteria, and they have three general knockout criteria. So these are the easy ones. If you can answer no to one of these, you can stop reading the paper, you're done, you can throw it away. So is the evaluated technology comparable to the one that's going to be used in the decision country? So actually, if there's something about the way the technology is delivered or the specific nature of the technology that's different, then you can't use it. And equally, if it's what it's compared to is different, you can't use it, because it's not actually addressing your decision problem. And finally, if the quality of the study is so poor that you can't rely on it, you also shouldn't use it. So those are their 3 knockout criteria, as they call them. But you're probably very rapidly not going to be considering, those aren't your problem ones, those are the easy ones. You'd come up with those ideas yourself. The question is, when a paper, a study is about something that passes the knockout criteria, but you still don't know whether you really use it. And so they talk about specific knockout criteria, where each transferability factor can be assessed, or each study, the study can be assessed against each transferability factor. And you assess it, how it is in the study and how it is in the decision setting, the decision country. If you can't assess it for either of those, then it's a no, because you don't know that it's relevant. So this is a risk-averse position. It's saying, if I can't confirm that it's relevant, then I should say no. I should reject this study. So it's risk-averse, and given we're spending taxpayers' dollars, I think we should tend to be a bit risk-averse. We shouldn't assume things. If it can be assessed, then you ask the question, is there a sufficient correspondence between the study and the decision setting for it to be useful? Okay? So it's a 2-stage for each transferability factor. Can I assess it? And if I can assess it, is there sufficiently high correspondence between the study setting and the decision setting for me to use it? Typically, if you find a specific knockout factor, some reason why you're going to say no to this, then the question is, can I do some local modelling work that overcomes this problem? Can I bring in observational data from here? Can I model the morbidity, the case mix, the epidemiology of the disease for Alberta rather than for Ontario, for example? So what we'll find is we'll, change the incidence and the prevalence, capture a difference in practice variation, introduce our costs rather than their costs. Quite often have to make adjustments for currency. So US dollars and Canadian dollars don't buy the same amount of healthcare. So we have to use purchasing power parity adjustments to make sure that that's relevant. And of course, there's always inflation. So a study done in 2010 may be perfect, except for the fact it's using 2009 prices. And we know that the cost of healthcare has gone up a little bit since then. And so we have to redo the analysis with today's prices. We have to adjust for inflation. In essence, you end up building a new model. So I guess if I was going to say, core message is, get over it. You're probably going to end up building your own model. But you can borrow a lot of expertise about good model structure and the evidence on effectiveness and safety that's from the trial from well-done studies. But in the end, you're highly likely to end up building a new model. So what I've tried to do is set out as a decision tree how you go through the steps to arrive at clarity. So, as I say, you start off with, have any of the general knockout criteria been met? If yes, we've got a simple answer. Study results are not transferable. But if no, well, apply the checklist. So the checklist is the specific knockout criteria, the specific transferability factors. You go through them and you say, has it met a specific knockout criteria? Do we have the data? If we don't know, if we do, is there sufficient correspondence through each of these? That's your specific knockout criteria. Is it met? If yes, then again, you've got a study that's not transferable and you have to walk away from it. If no, we might say, are modelling adjustments required? So we're not walking away from it, but the correspondence, could we improve the correspondence by using local data? If no, if we can't improve it, then we've got a study which is transferable. Good news, we actually don't have to build a model. Personal experience, it hasn't happened yet. But if you do ever find one, that'll be great. If you think you need to make adjustments, then you have to ask the question, okay, is the study completely clear in its methods and its data that I can identify what data I need and know which methods to apply to it to make this adjustment? Because if it doesn't tell you what it's done, then you can't make the adjustments. And so once again, you're going to have to throw the study away. If it does, well then, is the relevant data available here? They've told you what they've got and what they did. Have you got data about that in your setting? Because if you haven't got the data, then unfortunately, you're also then going to end up with a study because you can't make modelling adjustments that you can't use. Okay, so those are all the bad news. What about when you've got that data available? What do you do? So if it's fully available, that's just great. You substitute all the parameters, calculate the ISA, and tell the decision maker, and you have got adjusted study results that are applicable. So you've got to yes. If they're not available, well, we're back there. Got to throw that study away. But here's where we really live most of the time, to be honest. It's, well, some of it's available. Well, what do you do then when some of it's available? Well, use what's available. You substitute the data for the available parameters. You calculate the decision country specific incremental cost effectiveness ratio. And then you ask yourself, how far from a completely applicable study am I now? You know, you go through your checklist. Are there any remaining modelling adjustments that I would like to make? But the data's not available. So if there's some remaining, what do you do? Well, if you decided no, you're all right. But if you decide there is, what do we do then? Well, what we do then is we ask, are those parameters capable of changing the decision? So when you replace some parameters, you reduce the total decision uncertainty. And so there's a chance that actually you've reduced the total decision uncertainty to the point where actually the other things you don't know or you're uncertain about don't matter anymore because they can't change the decision. Or it's too unlikely that they could change the decision. And if you get to the point where actually the cost of getting more information isn't justified by the probability that that could change your decision, then you're good. Actually, you can work with that decision. If actually the things you are still uncertain about drive sufficient risk that you'd make the wrong decision using this study, even after you've adjusted as best you can, then again, you're in a position where you shouldn't be looking to use that study to inform decisions about resource allocation. But what's good is we have a clear process and we have a clear decision rule. Using the best available evidence we can to improve the relevance of this study, does it get us to a point where the risk of making the wrong decision is sufficiently high that we set this study aside? Or actually, does it get us to the point where, although we're still not certain, we're confident that any remaining adjustments wouldn't change the decision? It might change the ISA, but it wouldn't move the ISA from below the threshold to above the threshold, or from above the threshold to below the threshold. So that's one of the advantages of not being in a hypothesis testing world. New evidence only matters, and uncertainty only matters to the extent that it increases the risk of us making the wrong decision. Okay? And what we're trying to establish by following this checklist is, can we use this study, can we generalize this study without an unacceptable risk of it leading to us making the wrong decision? And if the answer is we can, then we can use that study. And we should use that study because it's efficient. So, if no, we use the study. So that's the decision tree for transferability. Now here's the summary. Generalizability and transferability are a concern for both evaluations alongside clinical trials and cost-effectiveness models. I think they're a bigger concern for evaluation alongside trials, because this is not what trials are designed to do. But they're still a significant concern for cost-effectiveness models. We tend to use statistical approaches to look at generalizability and portability for trial-based evaluations, but they're still, it's still an unsatisfactory state of affairs in terms of the ability of a trial-based evaluation to speak to a decision problem, because that's not what they're designed for. For CEA models, we need to think about the general and the specific knockout criteria. The general ones are the obvious ones about, well, is it dealing with the technologies that we're interested in? And is it good enough quality? If the answer to any of those three questions is no, then you can instantly set the study aside. But that's not normally the case, because you haven't searched for those studies. You've searched for studies that look like they address the decision problem you're interested in. Yeah? And for them, what we want to be is systematic. We want to use these systematic checklists and use them to arrive at a clearly thought through and transparent rationale for using or rejecting the studies undertaken in different places. Because if we aren't systematic and we aren't transparent, then the decision makers and other stakeholders in the decision-making process, the patient groups, the manufacturers, the clinician groups, will say, well, why have you done this? And they'll be able to criticize and overturn what we've done, which is no help to the decision makers. Decision makers need to be able to rely on what they do. If we do something that means the system, the process has to be restarted again because we can't justify what we've done, then we haven't helped them. We've cost them time and money and delayed patient access to the therapies that they can benefit from. So the key thing is systematic checklist for transparency and consistency. Final message really is that you're almost always going to end up building most of a local model. And so being skilled up in how to build those models and how to use local data, which is a particular strength and strategic priority here in Alberta, it's really important because you're very frequently going to get to a point in your review of a study where you say, I need to adjust this with local data. And so those skills are really important. Okay, I've also popped in the key readings in this area, the sort of 5 studies that are worth reading to have a look. Okay, any questions?
Great.